Hey everyone, welcome back to our conversation on GI patho. Let's jump into conditions affecting the stomach. Okay, so gastritis. This is basically just something anybody has had if they've had a stomach bug, or maybe if you drank a lot, or just ate something that didn't agree. So a lot of times the etiology is the stomach virus, but most all people have had an episode at some point is the truth. Incidence. So in younger folks, it skews towards an etiology of excessive ETOH intake. And in geriatric folks, it skews to an etiology of they're taking too many NSAIDs. So that's a non-steroidal anti-inflammatory drug. The classics being Advil, Tylenol, and aspirin. More so Advil, if I'm being honest. That's ibuprofen. So this is a transient condition by its nature. It might be accompanied by a little bit of hemorrhage or irritation or erosion to the mucosal epithelium, but hopefully not. That's pretty serious if it does. But it's associated with exactly what you would think. So somebody taking too much of a thing. And so the classics, again, are usually NSAIDs or ETOH. Other conditions can cause it as well, such as severe stress. Individuals who are making an attempt to commit suicide. And when they're doing that, they're usually taking a lot of pills or something like that, like they're trying to OD on something. Some systemic infections can cause this, severe food allergies, very heavy smoking, but the main two that we're worried about are excessive ETOH intake or NSAIDs. Presentation. An episode of anorexia, in other words, like cleaning out your guts through vomiting, nausea, there may be a little bit of blood in that vomit that's produced, pain that's above where the stomach is located, kind of a cramping to the abdomen. Sometimes it's accompanied with diarrhea, fever, or headaches, especially if there's an infection involved. Typically, if you remove the irritant, it'll resolve right away, which is good news. And so that's why an individual who drinks a lot or has taken a bunch of meds, they vomit it all up and then they feel better. So if you have a chronic gastritis condition, though, this is a little more concerning. So this is usually present when somebody has an anorexia condition or they have decent food intolerance. In other words, they really can't handle spicy or heavy fatty foods. And then sometimes there's an overlap with an H. pylori or a Helicobacter pylori infection. Note that about half the population age 50 and up has an H. pylori infection. So chronic gastritis, sometimes folks are asymptomatic, but sometimes they kind of always have a little bit of discomfort with GI intake. So that's something that wants to refer back to the physician, because again, we don't want acid where it doesn't belong, especially if it's regularly where it doesn't belong. So be aware that if you have a patient who's taking NSAIDs all the time, it's not unusual for them to have gastritis for this. If they have meds that they're supposed to be taking for chronic gastritis management and they're not taking it, then we're worried they're going to have this kind of secondary GERD and other issues, so that needs to refer back. Basically, they should take their medications as prescribed, and we're just looking to make sure that they're safe and okay. Another condition, peptic ulcers. So this is a chronic lesion to the stomach or a little further down, coming down into the duodenum. So this is actually about 10% of the US population. And the number one reason by far is H. pylori. The number two reason is NSAIDs. And the number three reason is, unfortunately, personality traits such as very high stress. So how does it look? Well, it's an epigastric pain. It's up a little high. A pain that tends to be worse at night. Again, this is the gravity sloshing that acid around. It can be accompanied with nausea and vomiting. Sometimes there's a bloating component to it. And then sometimes there's, it's painful when you eat. So these are folks who say, I feel better when I don't eat because then I don't have so much pain in my stomach. That's a pretty classic patient complaint for needing to be referred back for screening for peptic ulcers. Number one thing they're going to do is actually give you antibiotics, which is surprisingly effective because it knocks out the H. pylori. Otherwise, they need to avoid whatever the irritant is. If this is an individual who has personality traits for high stress, then maybe we refer them for mental health support. Once you've had a round of peptic ulcers, you're pretty likely to get it again, especially if somebody's a smoker. So for SPTs, we monitor for signs and symptoms of bleeding because that's what's really concerning. If somebody has a perforated or hemorrhagic peptic ulcer and it's in the posterior wall of the stomach or it comes all the way down to the duodenum, this can give them two referral pain presentations. One is kind of a vague back pain, and the other can sometimes be referral pain into the right shoulder. So we want to be aware that any of our patients with low back pain or right shoulder pain specifically, especially when you can't determine an obvious source, such as, oh, you obviously, throw a baseball all the time or something clear like that, we want to screen them for this and refer them back as appropriate, especially if we're thinking about that some folks have, two things can be true, right? You can have high stress and eat too many greasy foods. That's totally a thing, especially when you're stressed. And I have a picture of Daisy Ridley there, who played Rey in those newer Star Wars movies, who came out recently saying that she actually had perforated peptic ulcers from the stress associated with fans not liking her as a character in that franchise. So sometimes it's folks who actually have pretty good health, but the stress is really high. And so what I would say is there's the referral for mental health support that can be really helpful, or maybe we help them engage in a new exercise routine to help manage stress and decrease that component of their condition. Okay, so gastric carcinoma. Let's take it into a more serious territory, right? We were just talking peptic ulcers. Now we're going to move over to gastric carcinoma. So with this condition, this is actually, I'd say, a bigger issue in the southern states, in no small part because of its etiology. So intestinal type adenocarcinomas have an etiology that has to do with nitrates, which are a component of preserved food, smoking, salt, and then an issue with chronic gastritis. So what causes chronic gastritis? Fatty foods, right? There are different types of gastric carcinomas. We're not going to dig into that. We're looking more at the fact that diet and then behaviors such as smoking can play a role with this condition. So yes, if you have a not healthy diet, you can eventually end up with stomach cancer. The presentation here, initially asymptomatic. Once it gets more advanced, it can create issues with swallowing or dysphagia, abdominal discomfort, a feeling of being full really early, and issues with nausea and vomiting. One thing I would say here is by the time folks get symptomatic and realize they have an issue, the condition is often more advanced. Plus, early on, the symptoms are not particularly striking. It's general GI distress or kind of a vague heartburn, so folks can take some over-the-counter Tums or something and they don't realize it's actually more serious. Without meaning to, they delay seeing their PCP and the cancer has time to get a lot worse. So this is why screening is really important when we're thinking about age groups that are more at risk, and why I personally am not a huge fan of just taking medications to manage heartburn or to manage loose BMs all the time without thinking about why you're needing to take it. Sure, it manages the symptom, but you're not eliminating the problem. And that's something to keep in mind. So we'll dig more into this when we come to our farm conversation this summer, but it's something to keep in mind. I'm actually really not a fan of folks just popping things to manage GI distress. So what do they do for this? Well, the surgery is reasonably successful, but they are going to have to remove part of your stomach. And so the recovery from this can be extended. It's not unusual for folks to need upwards of a year to a year and a half to recover. If they're hospital side, you're going to be working very closely with the patient as they also in turn work closely with the registered dietitian or nutritionist. And it's really good to discuss kind of components with them because you don't want the patient to build some sort of intolerance for movement, like just the gravity and the exertional components. And it may be that there's intake things or timings that are really beneficial. And so you really want to collaborate well on an interdisciplinary level with the RD at work. So again, like I was saying, if they get in there, it goes well. But if they don't, getting caught late, this actually has a really poor survival rate when it gets more developed. So you don't need to know the specific image. This is just me showing you that gastric carcinoma can hit very differently depending on the type that it is. There's a lot of subtypes. Otherwise, your survival rate gets really low. So you want to catch this early. The big thing here, again, is somebody with pain that's kind of generally around the stomach or the back that gets relieved by antacid. So a patient coming to see you, they have back pain. You're saying, hey, does anything make it better? A classic PT question, what makes it better or worse? If they say, oh yeah, I just take some Pepto or some Tums and that makes it better, no, we're referring that back. That's a red flag for referral potentially, right? Okay, let's jump into the small and large intestines. So first thing we're going to talk about, because this is the function of these organs, is to absorb things, right? This is where, earlier in the pathway of the bolus of the digesting food, things were getting broken apart. Now they need to get absorbed. So malabsorption syndromes really run the spectrum. You can have defective absorption of all different kinds of things, whether it's carbs, fat-soluble vitamins, electrolytes, you name it. So this image here is really just to emphasize that it's specific to the condition on what isn't getting absorbed properly. And you can use your exercise physiology knowledge on knowing what happens when you don't get enough vitamin C or something like that, right? You might be eating enough of it, but you're not absorbing enough of it. And that's the kicker here. So presentation in general with malabsorption syndromes, well, it almost always happens with the BM. So if somebody has chronic diarrhea or a diarrhea that's frothy and fat-filled, that's called steatorrhea, that's a sign that malabsorption is likely happening. The BM might also be kind of strangely bulky, like there's too much of it to be typical. It's frothy, greasy, or the color is wrong. Yellow or gray are classic wrong colors. It's accompanied by weight loss or kind of an anorexia presentation, or they're having serious bloating. All of those are kind of classic presentation attributes. You don't have to have all of them, but a cluster of them may indicate that a malabsorption condition is occurring. And the big thing for malabsorption syndromes is that we want to be on the lookout for somebody who's not getting enough of something they need so that their muscles are healthy. That's where we really excel in screening for this. So unexplained muscle weakness and muscle wasting, accompanied by fatigue, unplanned weight loss, these can actually be signs of malnutrition or malabsorption, particularly of proteins and carbs. So if somebody doesn't have enough calcium or vitamin D, it's exactly what you would think. Skeletal abnormalities, bone pain, paresthesias, yeah, it can actually get serious pretty quickly. And then another thing we sometimes see in more of the outpatient setting are muscle spasms, bruising that seems to happen too much or it's kind of excessive. Maybe they get a cut and it takes forever to bleed, or it feels like they bleed easily. And then kind of a generalized swelling of limbs that doesn't seem to have any explanation. Yeah, you want to refer all of that back, because if it goes on long enough, you can get some really bizarre neuro. I'll tell you some stories during class of some weird malabsorption getting really, really far down the line. You got to really have malabsorption for a long time that's profound to hit neuro, but it is possible. Let's look at one really iconic malabsorption syndrome. I chose this one on purpose because I think discussing it allows you to understand other malabsorption syndromes. Plus, this one is one that patients tend to ask about a lot, so I think having a little more in-depth understanding is beneficial. Celiac disease. Okay, so this is a gluten-sensitive enteropathy. So the source here that we're talking about are components of things that are like a processed food that involves wheat, rye, or barley. So some piece of one of those things, it produces a gluten protein, and that's what people are sensitive to. So what happens over time is they build up a reaction to gluten, and this is a hypersensitivity reaction in some ways, because gluten does not necessarily pose a threat, right? Just kind of like how we were thinking about environmental pollens and things like that. Taking that in isn't necessarily a problem for the body, but the body reacts to it, right? And so with this particular thing, what's happening is that you have over time a reduction in the absorptive surface area of your intestine. So normally your intestines look like this. You can see the villi are nice and long. And what can happen is they actually become destroyed over time, and you end up with this flattening. So this is bad, right? You're not absorbing everything you're supposed to. This is kind of part of the etiology of what happens. We'll dig into this more. More people are getting this condition. Normally we don't have antibodies to gluten, but in this population they do have it. And so you get this autoimmune destruction of the intestinal tract, and this is actually pretty problematic for folks. Plus, in really serious, severe conditions of celiacs, the exposure to the gluten can be life-threatening for some folks. So thankfully, that's a small percentage of the population, but it does exist, and it's pretty scary for them. They're probably carrying around EpiPens. And despite this diagnosis happening more and more, like there's an increasing prevalence on the epidemiology, it's still considered underdiagnosed worldwide. And it can seem like some populations are more inclined, but it's actually any ethnicity at any age is subject to this condition. So let's dig in a little bit more here. I actually pulled an overview of the condition from, or a primer is sometimes what it's called, of the condition from Nature to get a better sense of this. And with some more modern numbers, like this graph here, this map is from 2019. That's decently recent. So what we're looking at here, and so the gray countries just mean they haven't done bigger studies that were reportable. That doesn't mean they don't have the condition. It's actually at its highest in areas outside of the United States. Yeah, that's kind of surprising, right? So all this is to say, like when you really think about it, and it kind of runs the spectrum for different backgrounds, right? So I think it's interesting to remember that as profound as it can be, like as common as it can seem in the US, it's actually in countries that are reporting their prevalence, it's actually more common outside of the US. Unexpected, right? Okay, so what are risk factors? Well, it's exactly what you would think. It actually follows the same sort of tracking as our conversations on anything with autoimmune. And you haven't learned it yet, or maybe you know this from undergrad or just general knowledge, that diabetes is an autoimmune condition. So, individuals, so for a sex preference or a sex kind of breakdown, would be women, as well as autoimmune conditions. If you have a family member, particularly a first degree relative with the condition, you have a 1 in 10 increased risk of developing celiac disease. And then again, if you have type 1 diabetes, you're likely to develop this in combination. So that's exactly what folks with diabetes need, right? More restrictions on their food intake. It's already an immensely frustrating and dangerous condition. The last thing you need is more. And yeah, that's how this tends to go. You have one autoimmune condition, others tend to follow. So note that among the conditions that the autoimmune conditions which are likely to get celiacs are genetic conditions. So there's certain HLA haplotypes. In other words, folks with certain presentations of their HLA protein expression are more likely to get this, as well as folks who don't make enough IgA, Sjogren syndrome, and then a number of other genetic conditions that, like chromosomal defect conditions, that tend to have a lot of autoimmune issues, such as Down syndrome, Addison disease, and Turner syndrome. That trio right there tends to get a lot of different autoimmune conditions. Okay, so I have a big, pretty slide here. I pulled some images off of that Nature Disease Review primer, just to give you a sense of what's going on here. This slide is going to be largely purple hexagon. In other words, it's a lot more than you need to know, which is why I have a little breakdown right here, and I'll go ahead and state that now. So in the pathophysiology of celiac, we get a really good insight into other food intolerances, which we're clearly going to see more and more of as the years go on. And the basic thing is, you get a protein from one of these foods or some component of the food as it's broken down, and initially you get this adaptive immune response in certain susceptible individuals. They build the antibody. Inflammation is also triggered locally. Okay, so remember that in the signaling, so this is me gesturing here, these are your intestinal epithelial cells, right? Notice how they have really nice villi. What happens as the adaptive immune response ramps up is that you get a lot of inflammatory cytokines, and all of that creates a local inflammation issue, okay? So in addition, the mucosa in this area are under distress, and that stress state causes them to experience hyperplasia. You get a lot of GI dysfunction as a result. You can also end up with some accidental kind of bystander damage and some autoimmune issues. So essentially, you have an inflammatory status, damage to the mucosa of the lining of the intestinal tract, as well as hyperplasia to certain areas of the mucosa, all generally leading to GI dysfunction. How do we even get there? Well, it's actually, interestingly, when they harvest wheat flour, it has different components, and what people are generally reacting to is gluten, which is a component of the protein. So here in yellow and kind of this orangey color, this is what is harmful to somebody with celiac disease. So what it really breaks down to, the categories are wheat, rye, and barley. In theory, oats, rice, corn, millet, and sorghum are fine for them to take in. There is some controversy on whether or not oats are safe in a gluten-free diet. My understanding is that this partially has to do with the processing of oats, that a lot of times oats are processed in a facility that also processes wheat, rye, or barley. So it's more of a processing issue rather than oats themselves being a problem. But I think it's reasonable that most folks with celiac can usually intake millet, sorghum, and rice. Some people avoid corn just because they're trying to be healthy, and corn it tends to be, you eat a lot of it. So, but otherwise, yeah, I mean, in theory, corn should be okay. So in this process here, what we have, again, is the presentation of an antigen. Usually dendritic cells are doing the presenting. And the antigen is something that isn't actually a problem, such as gluten. The immune system builds up reaction, and you end up with an immune response. So what happens over time, actually, unfortunately, is this. So remember those long villi that we saw? This is a histopathology that allows you to kind of see what's happening. And you can see that over time, this villi is destroyed, and you instead end up with the elongation of what are called crypts. So these are the structures that are below the villi, and you get hyperplasia of this instead, rather than these long finger-like projections, which should happen. Now, thankfully, you can reverse this. So in theory, the treatment should reverse it. So a gluten-free diet is the primary thing. There really isn't anything, at least as of right now when I'm recording this, no medication or sort of option that these folks have. It's unfortunately behavioral just through diet, which really stinks, It'd be nice if they could take something, but they really don't have options. One thing I would note here is that there's a technical aspect in the gluten-free diet that's really frustrating for a lot of folks with higher severities of sensitivity to gluten. And that is, we don't have the capacity scientifically to truly detect lower levels of gluten presence in food. That means that something that is labeled gluten-free, that is a technical definition here in the US, administered by the FDA. And it actually doesn't mean that something is perfectly 100% gluten-free. It actually just means that it has less than 20 parts per million of gluten. Why? Because that's the lowest amount we can scientifically detect at being like, for sure, it's really not there. That's a frustration. And so what this often means is that folks who have a higher threshold of strictness, in other words, they really need to be 100% gluten-free, basically can't trust the designation. So that's one thing to keep in mind there. So that means that for PTs, we need to be aware that we might need a really good dietitian to refer to, because this person's probably gonna have to cook a lot of their own food to maintain that safety threshold. We need to observe them for signs of malabsorption syndrome. And then I've just got some information here that's just of interest, because part of the challenge is that gluten-free products, even if you can tolerate them safely, often don't taste as good to a point where people don't want to eat them. There's that issue of accuracy. Sometimes people say things are gluten-free and they're not, as well as the FDA's definition compounding that. Gluten-free food is sometimes twice as expensive as gluten-full food, and there are cultural factors around food. Like maybe it's culturally important to eat certain foods at certain times of the year, or that's what their parents are making or their grandparents are making. So that's something to keep in mind. In addition, the Western diet, like here in the US, contains massive amounts of gluten. And it does appear that like very small amounts, again, that's milligrams, that's grams, so that's a lot less. A tiny, tiny little amount can still cause damage. You actually need an itsy bitsy amount in order for it to be harmless. So in other words, they end up in kind of a black and white scenario in which they basically have to completely avoid gluten in order to stay safe or at least comfortable. So factors to consider when we're interacting with our patients with malabsorption syndromes.